Good morning. This hearing will come to order. I want to welcome everyone, especially our good friends from the Subcommittee on Health, to today's joint hearing regarding VA's health information technology. Today we will examine the current state of key IT systems and facilitate scheduling and community provider claims processing. Facilitate scheduling and community provider claims processing, and we will delve into VA's plan for modernizing them. The VHA and OI&T share responsibility for these systems. We will also examine VHA's strategy for the IT systems that will be necessary to consolidate community care. My friend, Subcommittee on Health, Chairman Dr. Benishek, has done extensive work on the consolidation issue. VHA released a draft request for a proposal yesterday afternoon for the Consolidated Community Care Network, and we need to know the IT requirements. Currently, VHA relies on the scheduling functions of VISTA, the Department's health information system, which was originally developed in the 1980s. Since late 2012, VA has been planning to procure commercial state-of-the-art scheduling software. VA awarded a contract for this system called the Medical Appointment Scheduling System, or MAS, in August 2015. VA planned to conduct an initial pilot of MAS in Boise, Idaho through 2016, but it was never started, and activity on MAS has apparently been suspended. VA has simultaneously been developing an intermediate solution to improve VISTA scheduling while MAS rolls out. It consists of two parts: the VISTA Scheduling Enhancement, or VSA, and a self-scheduling application called Veteran Appointment Request, or VAR. VSE gives VISTA a modern look, similar to a Microsoft Outlook calendar. It replaces VISTA's black and white command prompt interface. VA has described VAR as, quote-unquote, limited. Recently, VA determined that VSE and VAR appear to meet its scheduling needs, and MAS is unnecessary. This decision is a dramatic about-face. It means sticking with the government-developed technology indefinitely. MAS has been stopped before. Even its first pilot, its first pilot could be compared with VSE and VAR. The plan was to see what solution works best. It seems we will never know. VA's claim processing system, called the Fee-Basis Claim System, or FBCS, is also badly in need of modernization. VHA claims processors use it to receive, examine, and approve claims for reimbursement from community health care providers. The volume of claims is up dramatically since the Choice Act, and the processors are overwhelmed. On this committee, we hear complaints from frustrated providers every day about not being paid, and VA lags far behind Medicare and TRICARE in processing claims. FBCS, as it exists now, has some fundamental limitations. Today, VHA has 34 groups of staff around the country processing claims manually on 34 disconnected FBCS databases. Claims come in electronically and on paper. The paper claims don't enter the system at all until they are scanned. And GAO estimates scanning takes about 2 weeks. The electronic claims are immediately viewable and trackable, but there is no national view across the 34 locations of paper claims until they are actually approved for payment. And there is never a national view of paper claims that get denied. Claims information is too hard to find, and it can get lost in the cracks. VHA's manual processing takes too long. VHA's policy is to pay or reject 90% of claims within 30 days. And GAO found that VHA only meets this standard 66% of the time. Instead of manual processing, Medicare and TRICARE use auto adjudication. Their systems automatically analyze claims for completeness and accuracy. FBCS can be upgraded to fix these problems. An upgrade to make the paper claims more transparent has been available since May 2015. VA still hasn't tested it. An initial auto adjudication upgrade could have been available this month, but it can't move until the earlier upgrade is implemented. VA has a major decision to make about whether to upgrade FBCS now or to wait to put it in a wholly different claim system as part of the consolidation plan. What is certain is we have a big claims paying problem right now, and payment delays chase away providers. I now yield to Chairman Benishek for his opening statement.
Thank you. Well, it's a pleasure to be here this morning with the members of the Subcommittee on Health and our colleagues from the Subcommittee on Oversight and Investigations. Ensuring that the Department of Veteran Affairs is fully equipped with a modern functional information technology system is a priority that we all share. Many of the deficiencies in the IT programs that underlie the VA healthcare system have already been laid out by Chairman Kaufman, and I agree with his comments regarding the urgent nature of the ongoing efforts to modernize the VA scheduling and claims processing. We cannot allow the failures that have characterized previous efforts in these two important areas to continue. We also can't continue to push decisions further down the road. Too often, IT projects have progressed to a critical decision point and then been abandoned in favor of another initiative or another plan. VA must realize that maintaining manual systems and deferring to archaic operating systems as the default cannot continue. We need a sense of urgency. As Chairman Kaufman noted, improving VA IT is also important to community care consolidation. Many of the key features of the VA's plan to consolidate community care under choice will require a contemporary IT infrastructure to support them. The VA has shared little information to date about what IT systems the VA intends to put in place to support community care consolidation, what those systems are going to cost, and when those systems will be up and running and ready to support the needs of veteran patients and the VA's community partners. I hope the VA is prepared to provide that information today at the hearing. I'm also interested in hearing today about how the Veterans Health Administration, managed by Dr. Shulkin, and the VA Office of Information Technology, managed by Ms. Council, are working together to build a modern IT program and the VA healthcare system that we need to serve our veterans. The independent assessment of the VA healthcare system that was required by the Access, Choice, and Accountability Act found that the VHA and the OI&T did not collaborate effectively with respect to planning and executing IT strategies for managing and furnishing health care, and often disagreed on priorities for executing strategic plans. I would venture to say that the disconnect is why so many previous health IT efforts have failed to achieve success. Ensuring appropriate coordination and communication between the VHA and OI&T is vital to moving the VA healthcare system toward the 21st century. I look forward to hearing some specifics from Dr. Shulkin and Ms. Council about how they're personally working together side by side to make these things happen. So thank you all for being here this morning, and I'll yield back to Chairman Kaufman.
Thank you, Dr. Benishek, for your remarks. I now yield to Ranking Member Custer for any opening remarks that she may have.
Thank you very much, Chairman Kaufman and Chairman Benishek, and I appreciate you taking the time for this hearing. It's an important one, and to my Ranking Member Brownlee, we appreciate the opportunity to be with you all today. The wait time crisis in Phoenix highlighted the VA's antiquated scheduling system and how difficult it was to use. And I have to say, for many of us visiting VA facilities in our districts, we're having these same conversations. VA has made a number of efforts over the last 15 years to modernize and improve its scheduling system. But as a result of the crisis, the Choice Act, enacted by Congress last year, mandated assessment of VA's health IT systems. And we know that modern IT systems and processes are critical to ensuring that patients receive quality, coordinated care, and that physicians and healthcare providers are not wasting their time for people who don't show up. As we found after multiple hearings and assessments, VA's outdated and cumbersome patient scheduling system was a major contributor to patient access crisis and remains a challenge. VA's announcement in 2015 of a contract for commercial off-the-shelf solution to replace VA's scheduling system seemed like a promising response to the clear inadequacies of the current system, and we were all encouraged by that. There was concern that this would not be ready until 2017, but it was a promising step forward. This year, this 5-year, $624 million contract was awarded in 2015. But now, after VA has spent $27.5 million on a pilot project for the Medical Appointment Scheduling System, or MAS, as the chair has pointed out, we're told that the project's been put on hold. At the same time, VA has continued with its own in-house initiative to update their scheduling system. This seems like deja vu all over again to me. VA has already wasted 9 years, $127 million without an update to its scheduling system after finding a commercial product and abandoning that for an in-house solution that could not deliver an adequate update. We cannot and will not let this happen again. And I can say that on a bipartisan basis, this is very frustrating for those of us who have been sitting here, and some of my colleagues much longer than I have. I want to know what VA is doing to ensure that its scheduling system, EHR, and healthcare IT infrastructure are able to meet the current and future needs of our veterans. This means that VA must work toward developing a healthcare IT infrastructure that is interoperable with DoD. And I think some of us in the class of 2012 will remember that was one of our very first hearings on this committee, was the frustration about the interoperability with the DoD. And the precious taxpayer dollars that have been spent searching for a solution. We need to ask regarding VA healthcare and IT, how does this better enable the VA to do what it should be doing, serving our veterans, providing and coordinating healthcare for veterans all across our country. We need VA's businesses processes to work so that community providers are able to treat veterans and receive prompt payment for providing care. I continue to receive complaints from constituents in my district in New Hampshire that feel abandoned and forced to navigate their own care outside of the VA. I have community providers who have stopped participating in the Choice program because they're not paid on time or the eligibility rules are simply too complex. Our veterans deserve timely, high-quality care. Health information technology has the potential to transform the VA into a leader in the delivery and coordination of health care, and a healthcare organization that leverages health technology to deliver the best health care to our veterans. But VA needs to do its part to properly plan, implement, and oversee IT projects. And I know that the two of you are relatively new to the organization, so we don't blame you for past faults. We certainly want to work with you going forward. But you need to understand that Congress cannot continue to give VA a blank check to spend on IT projects without results. So I look forward to hearing from our witnesses on their suggestions and solutions, and I yield back. Thank you, Mr. Chair.
Thank you, Ranking Member Custer. I now yield to Subcommittee on Health, Ranking Member Brownlee for any opening remarks she may have.
Thank you, Mr. Chairman, and thank you and Chairman Benishek for bringing this hearing together, and I thank my ranking member Custer for holding this hearing as well. I will be brief because I think my colleagues have already laid out the issues that this committee is concerned about, but I will say that our Health Subcommittee has held a series of hearings on different aspects of the Choice program. We heard from VA on billing issues, eligibility, staffing, and provider networks, and most of them involved some component of technology that needed to be updated or fixed. It's fitting that we now hold a hearing on information technology and where the VA is going on this issue. We know that as the second largest federal agency after the Department of Defense, VA runs the largest integrated health system in the country and is tasked with providing high-quality, safe health care to eligible veterans. So we need, and our veterans need, a very strong and healthy IT program to deliver that kind of care, and I will look forward to the testimony this morning.
Thank you, Congresswoman Brownlee. I ask that all members waive their opening remarks as per this committee's custom. With that, I invite the first and only panel to the witness table. On the panel, we have the Honorable Laverne Council, Assistant Secretary for Information and Technology, and VA's Chief Information Officer. We have also the Honorable David Sulkin, Undersecretary for Health. They are accompanied by Dr. Alan Constantine, the VA's Deputy Chief Information Officer. I ask the witnesses to please stand and raise your right hand. Do you solemnly swear under penalty of perjury that the testimony you are about to provide is the truth, the whole truth, and nothing but the truth? Please be seated. And let the record reflect that all witnesses have answered in the affirmative. Ms. Counsel, you are now recognized for 5 minutes. Very well.
Great. Good morning, Chairman Kaufman, Chairman Benishek, Ranking Member Custer, Ranking Member Brownlee, and all members of the subcommittee. Thank you for the opportunity to discuss the progress being made by VHA and the Office of Information Technology, what we call OINT, to provide veterans timely access to care. I do appreciate all the opening statements. I think your candor and the issues that you want to discuss are exactly the issues that we think need to be discussed as well. I'm pleased to be joined today, as the chairman said, by the Honorable Laverne Council, the VA's Chief Information Officer and Assistant Secretary for OINT, and Alan Constantine, the Deputy Chief Information Officer for OINT. Ms. Council and I joined the VA at the same time in July of last year. We went through the confirmation process together as partners, and during that process, we committed to continuing this partnership throughout the terms of our office. We began our work with one goal: to make VA work better for veterans. I'm proud to say that we are holding that commitment. VA has a history of innovation that is deep and indelible, and we are proud to be part of it. The creation of the Veterans Health Information Systems and Technology Architecture, what we call VISTA, is one of the flagship examples of that spirit. 40 years ago, leaders of VHA recognized that technology in healthcare had reached a monument of mutual opportunity, a time when patients and clinical needs were growing more complex and IT capability was quickly improving. VISTA was that result. That initial visionary leadership, the recognition of a key moment in time, the collaborative partnership of the technologist, clinician, and legislature led to the nation's first electronic health record and was the driver for today's healthcare environment. But that was 40 years ago, and much has changed. The veteran in 1975 had an average age of 46. Today, veterans average 60 years old. In 1975, we served 500,000 female veterans. Today, we serve over 2 million female veterans. In 1975, VA focused primarily on the physical needs of the average veteran. Now we have an ever-growing suite of comprehensive healthcare services, such as prosthetics and mental health. In 1975, VISTA supported a handful of clinical processes. Now it has over 200 applications, each having multiple processes, and there are over 130 different versions of VISTA throughout VHA. In 1975, the veteran was carrying a paper folded by hand between points of care. Today, the veteran's tech savvy. She has email, uses a cell phone, and wears a personal health tracker. As our veterans have changed, so has technology. We must keep pace, and we must make the right decisions to do so. We sit before you today with over 55 years of experience in transformational leadership. Today, we're bringing our years of industry experience and a sense of urgency that Dr. Benishek called for to our work at VA. As partners, we view every decision through that lens. When Ms. Council and I arrived, the VISTA Evolution Program was beginning its work on VISTA 4. VISTA 4 enables interoperability and focuses on care coordination, providing tools to better manage population health. Its development concludes in fiscal year 2018. We sit before you 40 years after the creation of VISTA and 2 years prior to its final development milestone, and want you to know we take our responsibility to do the right thing for veterans very seriously. We want to be certain that continuous modernization of a 40-year-old electronic medical record is an appropriate decision, as well as our approach to modernizing scheduling. We are asking our teams very difficult questions every day. Ms. Council demonstrated this commitment to asking difficult questions and taking difficult steps shortly after entering office. With the support of her team, she developed an actionable, far-reaching cybersecurity strategy and implementation plan for VA to Congress that was delivered in September 2015 as promised. VA, its core constituents, and external partners are all subject to a wide variety of cybersecurity threats. VA's enterprise cybersecurity strategy identifies key challenges and goals and is focused on building a comprehensive cybersecurity strategy that is aggressive, proactive, and addresses the unique needs of each of VA's business lines. This strategy is a major step forward in safeguarding veteran information and VA data with a complex environment, and we are proud of it. Our approach to the CHOICE program, or Care in the Community, is an example of the success we can experience through close partnership and critical evaluation. On October 30th of 2015, VA provided Congress with a plan to consolidate all VA's purchased care programs. This transformation will require a strong health IT platform that allows for bi-directional flow of information between providers and ensures continuity of patient care. The joint VHA and OINT team are working to take on this issue and meeting daily to ensure continuous progress and address obstacles. They are evaluating each health care and technology decision through a critical lens, ensuring we are making the right choices for the veterans and the taxpayers. In all areas of our partnership, we must choose our path carefully and strategically, as our work will lay the foundation for the next phase of VA's healthcare and technology environments. We are engaging industry leaders in technology and healthcare, as well as domain knowledge for our teams to ensure that the path we choose is the right one. As Ms. Council and I have the opportunity to evaluate more information from our healthcare technology initiatives, we gain more insight into which turn of the path will be the right one. We will share this vision with you this summer. We remain committed to making VA a better place for veterans, our employees, and taxpayers. We appreciate the opportunity to appear before you today, and we'll be pleased to answer your questions at this time.
Thank you, Dr. Shulkin. What's that? Ms. Council, do you have an opening statement? Okay. Thank you, Dr. Shulkin. And the written statements of those who have just provided oral testimony will be entered into the hearing record. We will now proceed with questioning. Ms. Council, what is VA's definition of sufficient capability in a scheduling system, and how did you determine VSC and VA, and how did you determine whether VSC and VAR met it?
The requirements driven by the business and VSE and both VAR, as well as the mass decision, were ones that were in place when we arrived in. At the end of the day, we have a joint team led by business leaders as well as IT. The business leaders have really driven the requirements, and then the IT organization is responsible for creating the technology. So we see it as one that would allow the veteran to get the demand met, and that we would have a clear understanding of the capacity to meet that demand.
The plan was to pilot VSC and VAR alongside MASS and see which is the best solution. How did you rule out MASS? How did you rule MASS out before ever piloting it?
Chairman, I'd be glad to take that. We have not ruled out masks. I want to be absolutely clear about that. Here's the situation that we faced, and I appreciate that the frustration of Congress in this, and I appreciate the input that you'll give us on this. But this is what made sense to us. VSE is available today, right now. It's actually in the field being used. I agree with Ranking Member Custer that the wait time crisis in 2014 was in part caused by an archaic scheduling system that is almost impossible to figure out. If you haven't seen it, this is our current scheduling system. It is DOS. It's what we used when computers first came out. This is VSE, okay? This is available right now, and this is in VAs today, in 2 VAs, soon to be 11 VAs with a national rollout in the next couple months. This makes scheduling errors a lot less likely to occur with this type of Microsoft Outlook type feel. So let me just give you the numbers very quickly, why we put a pause on masks. We did not cancel it at all. It is a contract that we can execute at any time. The entire VSE project, the national rollout, will cost taxpayers $6.4 million. It's available today. It will help veterans and schedulers today. If we roll out masks, which is an absolute option for us, the pilot alone will be $152 million. It will take us 10 months to roll it out in 3 sites. The pilot, as you said, Chairman, was to start in Boise, 2 other sites selected, 3 sites, $152 million, 10 months. And that's if VA stays on schedule with its pilots. So we felt the very, very best decision for veterans and taxpayers who we're trying to make these decisions for was to roll out VSE, because it's available today, and we're going to get it all rolled out this summer, make a decision very, very quickly whether VSE meets all the needs for veterans and our employees and taxpayers, and if not, we'll proceed with masks. We think that's a reasonable decision. If you have different thoughts on that, we're glad to hear it.
Ms. Counsel, why hasn't VA implemented the FBCS upgrade to improve tracking of the paper claims?
The requirements around paper claims are currently being developed with the Care in the Community team. We have the dollars, and the team is currently developing that capability. Alan, do you have anything you want to add? Only if you want to add something.
Only that we are, some of the VACA funds that we've received, we are looking at the fee-based claim system and making the improvements that we see are most necessary in the short term.
Okay. Ms. Counsel, what self-scheduling capability will VAR give veterans? How is it more limited compared to MASS?
The best way I can explain MASS is based on really capacity scheduling and work planning system within Epic. So it's a much broader tool. It looks at everything, all your resources, your workflow, and everything, not just the schedule. And that's why it is a larger, more impactful set of solutions. And the VAR which is the mobile device, which would allow the veterans to schedule, to cancel for mental health as well as basic care, is currently also going through process. So the VAR is related to the mobile, VSE is the enhancements to Vista, and of course MASS includes not only scheduling, but the much broader workflow, capacity planning, and everything you need around beds and docs and offices.
I would just add, VA needs the ability to have veterans schedule appointments themselves. There's no question about it. That's what veterans want, and we want that for them. VAR, again, is available today. I spoke to a doctor last night who works at the Washington, D.C. VA, and 25 of his patients at the Washington VA are using VAR. So you can actually schedule mental health, primary care, cancel appointments on your mobile phone. It is planned to be rolled out to 7 additional sites in the next month or 2. So that is, again, an immediate solution. Whether MASS provides a better opportunity or not, I think we are going to decide that in the very near future. But our goal is to give veterans tools today because we still have an access crisis, and we have to act with the urgency that I think all of you have asked us to act with.
Ranking Member Custer, you are now recognized for 5 minutes.
Thank you very much, and thank you for helping us dive right into this. And as you can tell, we're not IT experts, so the acronyms can take us a minute. I want to start, and I think I've asked some of you this before, but I just am curious. A couple of years ago, I met with a company. The name of the company, I believe, is ZocDoc. Do you know this story? So about efficiency, because one of the things that we deal with, we want to serve the veterans, and we're tasked with protecting the taxpayers. And the story that I hear over and over is veterans miss appointments because maybe they can't get a ride, maybe it's scheduled 2 months in advance and they don't get reminded. And this system is an IT system that improves efficiency by having reliable patients scheduled in the morning, less reliable patients in the afternoon, but you can double book in the afternoon, so we don't have physicians waiting around for patients who don't show. Do you know about this? Have you talked to them? How could we speed this up? They could help you.
First of all, I've known ZocDoc since they were a little tiny startup in Manhattan in 2007. It
Just seems like one of those great ideas.
No question about it. There are many, many commercial companies out there. ZocDoc clearly is a leader in that area, but I know this field extremely well. We need this capability. You're exactly right. This is what VAR was developed to do. Whether VAR meets all the requirements and whether we should abandon it and go with a commercial system, I think that we're open to that. What we don't want to do is start over when we have VAR that actually is ready to be put out into 7 of our VAs.
So, and my time is limited, I don't mean to be
Yes.
rude. So VAR, you're in pilot right now for veterans to be able to self-schedule, and will that be tiered that way so it's done efficiently from the workflow end of things, from the VA end of things?
It does not have all the features that you've talked about adding the ability to overbook and capacity management. There may be some more features of that in what Mass has, and that's part of what we're going to evaluate. But what it begins to do is to let veterans schedule appointments themselves or cancel appointments
Which
themselves.
is also very important. My father-in-law used the VA. It's important to know when you can get a ride there, when it works for you. And then I want to follow up. So I'm beginning to understand the big picture. Mass is a much bigger platform. It's going to be able to deal with the work processes, et cetera. Can you give me a few specifics? 2 minutes, and then lots of people are going to ask you the same question or more. What's the timing? What can we expect? And what's the cost? And we want to work with you. We want to solve this problem. We will go to our colleagues, Rs and Ds, and ask them for the funds, but we need some accountability.
I'll try to do it briefly and then ask Ms. Council if she wants to add anything. I think you mentioned this in your opening statement. The project cost for Mass is up to $624 million. The pilot alone for 3 sites would be $152 million. We have spent to date on Mass in the planning $11.8 million.
Okay.
The entire cost for VSE, the alternative scheduling system, is $6.4 million.
Okay.
The rollout for VSE would be over the summer to do a national rollout. The rollout for Mass would be a 10-month pilot at 3 sites,
Okay.
which we could start at any point if we want to. And then the rollout nationally beyond the 3 sites would be a much longer period of time. I don't have the exact, but I would guess it would be a year or greater.
Could we, my time is almost up, but it occurs to me, could we come and have a demonstration so that we could actually understand? I mean, for the taxpayers, 6.4 million sounds better, but obviously it doesn't do the same thing. And we want long-term savings, long-term accessibility for physicians, capability for the whole system. But the frustration we have is that we keep hearing about great systems and then we get halfway into it and then it didn't work, so we gave that project up. And, you know, where I come from, 600 million, that's a lot of money. That's That's a lot. So I'm going to yield back, but I'd love to, if we could work with the committee to
We'd be glad to
schedule
do
the
that.
demonstration so we have a better understanding.
And what we're trying to say very transparently is, we think it's a lot of money too. We're trying to make the best decision for, exactly as you're saying, the veterans and the taxpayers, and everything's on the table. We'd be glad to show you this and get your thoughts on it. Anybody would be welcome.
That'd be very helpful. Thank you. I yield back.
Thank you, Ranking Member Custer. Dr. Benishek, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. Good morning. Ms. Counsel, in the past, you've testified that thanks to a joint VA and DOD effort, we expect that interoperability will be certified with the DOD as defined by the 2014 National Defense Authorization Act, 8 months ahead of the December 2016 deadline. So that's where we are today. What's the story with that?
We have a interoperability agreed to. We are interoperable with DOD on the JLV, and that took place on April 8th. So DOD and VA have that handshake, and we are fully interoperable 8 months ahead of schedule. In
So
August,
if I go to the VA, then I can get the patient's DOD record for not every veteran, but what's the story? How many veterans actually have access to their DOD if I walk into the VA?
Yeah, so April 8th, we've signed off on it. It is attested. We are interoperable. Today, 55,062 active users in VA and 60,000 users in the Department of Defense are able to do exactly what you're saying, able to get access to the records on any serviceman or member of the VA. And that number will grow to 120,000 during the course of this year of users.
So that's, I mean, VA personnel have access.
55,000 are using it today.
How many veterans are in that?
I actually do have that number. It is, let me get back to you, Dr. Benachek, with the exact number, but I was reviewing it last night. I think it's several 100,000 veterans. Records have already been accessed through the Joint Legacy Viewer.
exactly.
Yeah, well, that's, the key issue, right?
Yep. Oh, here, I'm
It's
sorry.
1 million, I think.
What? 457, 265 veterans are, that's through the Health Information Exchange. Let me get you the exact number through the Joint Legacy Viewer.
All right, well, you understand the point I'm trying to make is that, so 60,000 VA employees have access, but are there, are we actually taking, is there a significant amount of veterans that we have access to those records? So that's a key issue. I'd appreciate that. The other issue that I'm interested in, and then it's already come up a little bit in testimony, is the self-scheduling piece. I mean, as you know, in the private sector, people schedule their own appointments. So you talked about it a little bit with an app, but that doesn't help most of the veterans that I deal with, because, they can't figure out how to use an app on their phone. That's just a limited amount of people, I think. So what's the timeline for that, and how is that going to actually work for most people?
Well, you're right. There are two ways to give veterans more control of the experience of scheduling appointments, which is what our goal is, to put healthcare back in the hands of the veterans. So there is the app, and increasingly more and more people are comfortable with smartphones. But even the veteran population does lag behind the general population. So we have to wait until more people catch up on that. The other way, of course, is the telephone. And this past week, we announced something called the Declaration of Access that will put the decision about scheduling and canceling appointments into the hands of the veteran. We have a system right now that's very, what I call paternalistic, which is called a recall system. We actually tell you when you're going to come for your appointment. We're going to stop that.
Yeah, I understand that problem.
Yeah.
So is the eligibility going to be all figured out in advance then? I mean, will the patient have opportunity to schedule an appointment in their locale, in the private sector, or at the VA? Tell me how that's going to work.
Actually, the largest users coming on JLV are actually the VBA and the benefit side, so they can be ahead of the eligibility question. We only expected to have about 35,000 users of JLV, and we are actually, numbers
JLB,
keep
what's
going up. So
JLB again?
the JLV is interoperability capability, so you can see the joint legacy viewer, so you can actually see the eligibility of the active duty soldier and then why they will be eligible as a veteran. It's really important that it's interesting that the VBA is really one of the bigger users now, and that's really helping to make this eligibility happen faster and much more accurately.
I guess I quite understand that, but I'm going to follow up with you later since I'm out of time.
Thank you, Dr. Benishek. Ranking Member Brownlee, you are now recognized for 5 minutes.
Thank you, Mr. Chairman. I just wanted to go back to the joint legacy viewer, and you said you were going to give us the number of veterans that are on there at this particular point. But I'm just curious to know, is it generally within the population of new veterans, or is it, you know, veterans after 1975, or is it's a random number of veterans across the spectrum?
No, it's not random at all. It is the holistic look at the DOD.
No, I know. Just in terms of the capability we have right now, in terms of numbers of veterans, you know, within the system that users can actually see. So I'm just wondering, is it sort of, did you start with the most current ones and go down a list, or is it random across
No,
the board?
it's not random. It's just taking the information that the DOD holds and actually finding that veteran and mapping it with the information that the VA has if they're coming into the VA. So it doesn't take it based on newest first or easiest first. It is the active duty records tied with the current state health.
But right now, it's limited because it only has a current amount of veterans, no?
No.
Okay, then I'm
The limit,
misunderstanding.
no, I think what we're talking about are users. When we say users, those aren't actually patients. Those are users, docs, people that leverage the information.
Okay.
I did find the number I was looking for, that Dr. Benchek asked for, which is that we just last week reached more than 1 million record lookups in the Joint Legacy
Okay.
Viewer. So those are veterans.
Okay, very good. So on the scheduling piece, so for the choice program, then veterans, will veterans be able to call the VA, find out if they're eligible, and then make an appointment with a community doctor?
Well,
How will that work?
well, today,
I mean, because some of that problem
Yes.
with the choice program is waiting for the VA to say whether you're eligible or not.
today we follow the current rules of
Right.
choice, which is to use the TPA,
Yep.
where you have to call and
But
get
ultimately,
eligibility
will
through
we
it.
get to a place where the veteran knows he or she is eligible and can make the appointment with a community doctor?
That's exactly our hope.
Very good. And so another question that I have, it seems as you lay it out, VSE versus mass, it seems like you're making the right decision going down a path that is going to be veteran-centric, help the taxpayers, and a quicker time frame. So that all, that all sounds really good. My concern is, are we building that system on a sort of a weaker foundation, i.e. VISTA? VISTA was at one point in time, way back when, a state-of-the-art system. It is no longer. And so as Ms. Custer was asking, the longer-term ramifications here, are we building a network of strength that is going to sustain over a period of time and really make the VA a veteran-centric, veteran-friendly system?
Yeah. Chairman Brownlee, actually, Dr. Shulkin and myself had this conversation at the end of last year, and we decided that we needed to lay out a new strategy as it relates to EHR and what a great veteran experience healthcare system would look like, because it is time. The EHR today is really just the heartbeat of the organism, but it does not have everything that is needed to mandate and manage care in the community, to deal with the needs of the female veteran, and also to support just the overall veteran experience and the clinical management. I have given to Dr. Shokin the recommendation around a state-of-the-art, world-class system. He is evaluating it from a clinician's point of view, which is the appropriate thing to do, and that's why he's laying out as the summer would be when we can unveil that, as this is what we suggest that the VA does. What I will tell you is it is incredibly responsive. It is aligned with the world-class technology that everyone's seeing today and using today, and things like Facebook and Google and other capabilities. But it also is agile, and it leverages what is called a FHIR capability, which is fast health interoperability resources, which means we can bring things in, we can use them, we can change them, we can respond. And so when he and I spoke about it, we sort of did the right leap. And we said, what we're going to do. We believe that VA is an innovator. We believe that VHA in healthcare should continue to be one. And we have provided an innovative solution based on industry experts coming back and assessing it as that.
Thank you. I apologize, Mr. Chairman, and I yield back.
Thank you, Ranking Member Brownlee. Mr. Lamborn, you're now recognized for 5 minutes.
Yeah, thank you, Mr. Chairman, and thanks for having this hearing along with Dr. Benishek. Ms. Counselor, Dr. Shulkin, I understand you are working on another contract to provide program integration support to the choice consolidation, and it has IT and non-IT elements. Are you going to combine the IT work with the non-IT work or separate them?
As you know, we have asked for the access to the 802 funds to be able to improve the choice program. Of the $421 million that we have asked for to build the infrastructure for the new Veterans Choice Program, about $300 million is for IT, and the rest are non-IT costs. So they are essentially combined at this point into the combined 421.
Okay. Okay, good. That was good for background. Ms. Counsel, your written testimony says VA has obligated $510 million in development funds to build VISTA capabilities since fiscal year 2014. VA has also obligated $151 million in IT sustainment funds and $110 million in VHA funds. So with all that spending, what new capabilities does VISTA have as a result of this money spent?
From 20 to 2013 till now, enabling interoperability, doing the JLB, putting in what is called eHemp, which is our web capability, which is actually a long-term interoperability, fully interoperable with DoD solution, which we're moving to. So the JLB, the Joint Legacy Viewer, is part of the solution. EHMP is the web-abled, which moves you to a fully interoperable data set, working with DISM. In addition, there have been clinical needs, lab needs, and different things like that implemented into VISTA. Also stabilization. When you look at the sustainment costs, what you're really seeing there is the maintenance cost for the 130 different instances of it, keeping the data centers up and all the equipment related to that. And that's what's in sustainment.
Okay. All right. Dr. Shulkin, if a VA hospital is manipulating wait times, as we have seen with some of our OIG reports, how is a self-scheduling system like VAR going to put a stop to it? In other words, couldn't someone, and I hope this would never happen, but like I say, we've seen otherwise, couldn't someone just change the information in VAR on the back end?
Your concern is one that we are very, very concerned about. We have 25,000 employees doing scheduling today. So that's a large system to have everybody doing it exactly right all the time. The two things that will help, number one is VSE, this is the new scheduling system, makes the likelihood of committing scheduling errors that we've been seeing less likely, because it's instead of that DOS system, it's a much more intuitive system that actually hard codes some of these decisions so you can't change them as easily. VAR, which is where the patient will schedule directly, would be very hard to change the data. Once the veteran, it's like a transaction in your bank account. You know, once the veteran pushes the button, it schedules it and it records it with an electronic, digital print. So it would be much less likely that there would be individual manipulations.
Okay, thank you, Mr. Chairman. Thanks for having this hearing. I yield back.
Thank you, Mr. Lamborn. Mr. O'Rourke, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. Secretary Shulkin, I really appreciated your opening comments and the hearkening back to the spirit of innovation and leadership that allowed the VA to develop VISTA and the nation's first electronic health record in the first place. And in answer to some of my colleagues' questions, taking the long view on how we establish a base and a platform from which we can do great things again. I think that's the spirit that we need to approach this with. And I know it's a real challenge because there are some basic questions of competency right now in the VA that are totally legitimate. And I think many of us and our constituents want to make sure that we at least reach competency, but that cannot be the goal. I mean, it's got to be excellence. And I think in whatever the VA evolves into over the next 10, 20 years, the ability to schedule and expertly manage the patient's medical information, share it between the VA and DOD, and then VA and community providers is critical. And so I just want to make sure that we're approaching these challenges the same way they did 40 years ago. Let's find out whatever they were drinking back then and make sure we order a case of that for you and your team. Approach this with that same vision towards innovating in medicine globally. I mean, that's the VA's rightful role, and that's what we should expect for our veterans. And I really think your vision that you outlined with us in October, which focuses the VA on where it can truly excel and then leverages capacity and competencies in the community that complement what the VA does, is the way to get there. I think that allows you to focus on what you can do really well. So I wanted to make that statement to just compliment you on your approach. And really my only concern is that you just started in July. And if conventional wisdom holds, you will leave at the end of this administration. It is my sincere wish, and I'll do everything I can to make it happen, that our next president keeps this team in place so that we have the continuity and consistency to carry this out. I think that's really important. What are the near-term milestones, and I know you've answered this question in different ways from different colleagues, what are the near-term milestones that will lay to rest any concerns we have about competency, and then also about executing a long-term vision that's going to allow the VA to develop excellence in this field? What should we be looking for in the next 7 to 8 months?
All right. Thank you, Congressman, for your comments. Let me just make one historical correction to this. The truth is, the history of innovation with the EMR in VA was actually that the administration did everything they could to stop the EMR. It was actually done by the people in the field who had to hide their efforts until an Undersecretary, Ken Kaiser, actually said, you're allowed to bring this out of the basement into the field. So we're trying not to make that mistake. We're trying to actually innovate and to help the field actually give us the feedback so that we can do what you're asking us to do.
That's great.
I think the short-term objectives that we have are really to focus on the veterans' needs. This is why when we're rolling out the VISTA scheduling evolution, when we're rolling out the VAR, the self-scheduling application, our evaluation criteria are asking veterans, did we meet their needs? And so those are the short-term goals. And we should have this information very, very soon, this summer, as we're rolling out both VSE and VAR, we are doing constant evaluations, asking our veterans, are their needs being met in terms of access?
So the milestone measurement is determined by the veterans
Yes.
themselves. And it's not the VA directly asking, or is it that, or is there a third party whom we can trust that is got an objective distance from the VA to make sure that we're really getting the unvarnished truth about the success of this? That would be my preference.
Yeah, and it's a little bit of both. The way that we're asking our veterans is actually several ways. One is we use a standardized federal government survey that is in the government called a CAP survey, which is done by every healthcare institution. That is done by a third party, so we hire a third party to administer that. We also ask our veterans when they come to appointments, there's a kiosk. So we actually, in the kiosk, ask them, how satisfied are you with the ability to get this appointment when you needed it? So they're entering that data.
And I'll just say this real quickly as I wrap up. I think it's critical that we ask those veterans not physically in the VA, because there are many who could not get an appointment, and we want to know about their experience just as much or maybe more so than we do about those who could get in. And as you've heard me say countless times, especially when it comes to mental health, because of the connection to veteran suicide, got to make sure that we know about their experience in being able to get an appointment, and then the VA honoring that appointment.
Yeah, and we generally get that feedback from you.
Thank you.
yeah.
I'll yield
Yeah.
back to the chair. Thank you for your answers.
Thank you, Mr. O'Rourke. Ms. Wolarski, you are now recognized for 5 minutes.
Thank you, Mr. Chairman. Dr. Shulkin, you had already addressed, I think twice, on VSC and VAR, the cost, the initial rollout cost, that kind of thing. Do you know what the lifestyle costs are to run those two programs?
The sustainment costs? I don't know that.
Well, there are no marginal additional sustainment costs in VSE. VSE is an augmentation of the VISTA scheduling package. So the same funds that would go toward the support of the VISTA scheduling package will be sufficient to support the enhanced VISTA scheduling package with the VSE enhancements.
Okay, and you know, I'm kind of asking that question because I'm sitting here listening to this. I'm cautiously optimistic, and I appreciate what your team has done. I really do, because I think you've taken great steps forward. And kind of just echo some of the questions my colleagues had. You know, I haven't been here long, but in the 4 years that I've been here, this issue with IT seems to be the one that continues to bounce back with some of the best efforts that have gone forward, and best trials, and then seems to bounce back, and all of a sudden, I'll never forget the hearing where, you know, the VA was $1 billion short, and you needed that to go to the future. So I'm cautiously optimistic, but Ms. Counsel, in your written testimony, you stated that the JLV provides limited VA to DoD medical record sharing compared to the eHemp you're working on now. Is it true in order to make eHemp work, you have to get rid of Vista's old user interface and implement a new one that integrates with the net, with the internet?
You actually have to integrate it into the web, and so you have to go through one at a time and lay that in.
So you don't need to get rid of the old Vista program?
No, because it actually can still live.
Okay. And then my final question, I think you may have answered this, is, Ms. Counsel, OIT is strongly advocating agile software development and project management. What specifically is OIT doing different now? VA's been talking about its leadership in agile among agencies since 2014.
Yeah, I'm excited about this. One of the things that you should have received was the VIP process, which is now standing up. That is our Enterprise Portfolio Management Office. That is our intake process. So if you look at PMAS and you compare it to what we're doing now with full Agile and VIP, we reduced the time that we were spending in document preparation by 88%. We went from 55 documents to 6 plus available to operate. We are in a full Agile capability, which means that you're following the 80-20 rule, which we will be able to produce in 70% faster time with better quality. We have the intake process, which allows us to assess the business case, and if something does not have a viable business case, it will not get done.
And I don't want to interrupt, but let me just ask you this. So I really do think your presence to this conversation has been incredible. I really think you have brought this so much farther, so much quicker than some of the folks have in the past. And so I really appreciate what you've done and how open you've been with our committee. And I guess, you know, from my perspective, and, you know, I really want this to work. You know, I want the calls that we get in our office to decrease. I want our veterans to actually find a seamless, smooth transition. And I want this to work, you know, just as much as they do. And I'm concerned, you know, as we talk about, you know, another rollout, another this, another that. And to echo what Congressman O'Rourke just said, is there a plan in place, given the political realities of how this continuity often gets interrupted? Is there a plan now, for example, that says no matter who is behind this seat, this is what's going to happen, that actually is a plan in place that really is not going to be changed, and another, you know, another development program with another, you know, $20 million or whatever? Is this going forward regardless?
Yes, that was the main purpose of how the strategy was defined, because that was my biggest concern. I didn't want to spend the effort either and not see the team continue. So, you know, we've added an additional 11 new leaders within OINT. We've added 7 new senior leaders who will be out into the field.
And let me just ask you about those leaders. Are those leaders competent in the private sector, competent folks like when you came in and you come in with all this competency and expert? Are these the same kind of 11, or are these people that are just elevated inside the VA?
Now, these people are coming from outside and private industry as well as from other agencies. They're highly rated, and we are very competitive. I am excited to say that when we look at, even actually Dr. Constantian here is an account manager for VHA, and that's why he's here. There are now standing account managers within OINT that didn't exist before, so that we actually have a head-to-head relationship with our business partners and have an aggressive conversation about the work that we're doing and how we're spending our dollars.
I appreciate it. I'm out of time, and I appreciate it, Mr. Chairman. I yield back.
Dr. Ruiz, you're now recognized for 5 minutes.
Thank you, thank you. Last year in testimony to this committee, Secretary McDonnell said the following regarding the VA's accomplishment, quote, "We were the ones that discovered that aspirin was important for heart disease. First liver transplant, first implantable pacemaker. Last year, 2 VA doctors invented the shingles vaccine. That research is important for the American people, and I didn't even mention PTS or TBI or prosthetics, things we are known for. So, Ms. Counsel and Dr. Shulkin, please explain why the VA is unable to develop or acquire the technology possessed by most modern healthcare systems and required to efficiently share health records and schedule appointments, yet can continue to make such progress in other areas of the department. What are your logistical and political barriers?"
We appreciate the question and the recognition of VA's track record of innovation. VA is a leader in electronic medical records. There is no system that has the extensive experience with EHR than VA. I will tell you, I've spent my life practicing in the private sector. I've now practiced in the VA system. It's my first time using the EHR, and our clinicians really like the Vista EHR. What Ms. Counsel is saying is, and I think what Congresswoman Brownlee was getting at is, the world's changed a lot. And is this 40-year-old EHR going to be the system that VA should stick with for the next 20 years? And that's where Ms. Counsel saying, we owe it to veterans and to all of you to make sure that we believe that's the right answer, and that's where...
Well, I think
Yeah.
you got to be careful with that notion, because healthcare information, diseases, record keeping changes, and it's flexible. So you can't make a guarantee that what we have now is going to last 15 years, because we don't want it to last 15 years. We want it to change with the ever needs of the patients and the community. And so you gotta manage some expectations that, that the information we get changes. So I don't, if you say you're gonna pick one and then you're gonna keep that same one for the next 15 years, then you're setting yourself up for failure. And you're also going to keep an archaic, 20 years from now, system in place just because you've committed to that.
I think I may not have been articulate enough. I think we're agreeing with that.
Okay.
Which is saying today Vista is actually 130 separate Vista systems. And new technology puts stuff in the cloud and makes it a singular system so you can be more agile and change it.
And I think one of the most important things you can do, other than creating a more modern, flexible system that matches the needs of the patients and the doctors where you practice in order to provide the best care, is to make it interoperable with the private sector. In the private sector, they're having difficulties in doing that themselves.
Right.
So it would be helpful if you could lead the charge to make sure that you do that, because if I'm an emergency physician and I see a patient that's a veteran and I can't get the last CAT scan to compare their abdominal CAT scan, or I can't get their latest EKG, then I am limited in the decisions that require resources that I can make. And more than not, because I care about the patient, I will not take the risk for the patient, and I will do what I need to ensure that the patient is going to be healthy. And that means more cost simply because I can't access a CAT scan or an EKG from another institution.
Exactly. And so, Congressman Williams, that's the solution that we've laid out. The one system actually does that in the cloud using software as a service. It builds around, I mentioned earlier, the FIRE concept, which is fast health interoperability resources, which allows you to pull those resources together, use that information, and redeploy it back out.
With the private sector, not within you.
Totally with the private sector, and we believe that the VA should be the leader in this as the largest health integrator and actually drive that forward on the HL7 platform.
Thank you. Yield back my time.
Thank you, Dr. Ruiz. Mr. Huelskamp, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. Chairman, I appreciate this joint hearing on this topic, and apologize for my tardiness. I want to follow up on just a few things, and apologize if they've been covered before, but the strategic hold on the MAS system, can you describe that for me if you haven't already for the full committee? And I was kind of curious what a strategic hold is versus a non-strategic hold.
I'd be glad to do that briefly, Congressman. We do have a contract with MAS, and we could execute that at any point. We've decided, since we have a system that's currently available, VSE, Vista Scheduling Evolution, that is being rolled out as we speak to VAs, to roll that out because it's in the best decisions right now, since it's available to veterans and to taxpayers to do that. We will have that done over the summer and be able to evaluate, did the Vista Scheduling Evolution meet the needs of veterans? And if not, then we'll proceed with a pilot for MAS, which would be a 10-month pilot at 3 sites at a cost of $152 million.
So what have you spent on MAS already, and that's all on hold, and that
Yes.
If it doesn't go forward, we lose all that?
Yes,
wasted money?
$11.8 million to date on MAS already. The Vista Scheduling Evolution total cost is $6.4 million.
Yeah, and Vista, you talk about rolling it out, it's still just pilot, correct? We're not rolling anything out, we're still testing it, beta testing it?
Yes, today it's actually being used in 2 sites in Asheville, North Carolina, and Salt Lake City. I have the user evaluations, which I reviewed last night, which are tremendous in terms of its receptivity. It's planned to roll out to 11 total VAs by the end of this month or within 6 weeks, and then a national rollout.
You mentioned Salt Lake City. I'm looking at testimony. I don't see that on the list of the VSE IOC sites.
Yeah, I'll be glad to share. Actually, last night I have it on me. I'd be glad to share the user feedback from Salt Lake City.
Okay. How seriously did you consider a commercial alternative to the contract, which apparently strategic hold could be abandoning that work and doing it with Vista strategically, or what did you consider on the commercial side? And I know ZocDoc was mentioned. I haven't used that. I was looking at preparing for this hearing, but describe the process by which you decided not to use any commercial alternatives.
Well, MASS is a commercial alternative. It's made by the Epic company, which is a leader in health information systems. It was selected through a competitive process, and we do have an IDIQ contract with them that we could execute at any point.
But it's an operating system?
Oh, yes.
And so you spent how many dollars just to look at?
11
million, and
$11.8
you never, did you ever use it as pilot program, or
No.
even try it?
Nope, the pilot program would be $152 million to implement because of all the interfaces and the spread. So that's the decision which we're facing right now. We decided, you called it a strategic hold, is that it's in the best interest of taxpayers before we proceed with $152 million to see if VSE, which is in the field now being rolled out, meets the needs of veterans. If not, we can proceed with MASS.
Yeah, just still, maybe you can follow up with something later. If went down the Mass Road for a while and then apparently have abandoned it. Strategic hold is your name, not mine, and is trying to figure out how we got there. Now we're back on something that's, been around for decades and trying to make that work. Here's another question, and more directly or I guess more broadly on this. Does anything in the choice legislation or other current statutes require us you to set up a system in which a contractor or a third party or somebody other than the veteran can make their own appointment?
Not that I'm aware of.
I'm not aware of that in the legislation.
So you're free to do that, and
Yes.
And that's what bothers me more broadly. I think we're still, what I'm seeing is just kind of this attempt to push them through a model which doesn't work, in my opinion, in the 21st century. Maybe it works for a few folks, but it's also, for instance, we've got another system out there with many of the veterans are in other systems. Many of them are in Medicare, and this is not the Medicare system at all. We don't require you to go to through Medicare to make an appointment, but somehow looks like the track is still push veterans through this system. Can you describe a little bit more why we still think we've got to push it through a system rather than letting something like a commercial alternative where you don't have to call the VA, you don't have to work through the contractor, you call the hospital and do like you do for Medicare. Again, these veterans, many of them go through the Medicare system. That was one of the concerns, that the cost would be so great of choice because folks would abandon Medicare or other options because the VA system would work so well, and it's not quite happened that way. So, but just more description of that. I'm concerned about still trying to put us in the same old model from 30 or 40 years ago, which I don't think fits our needs of veterans in this century.
Yeah, VA has a long history of using care in the community for veterans. We've been doing this for a long time. You used to have a system, I think, like you were describing, where veterans would seek care in the community and we would go and schedule it, very similar to the way that you schedule with Medicare. The choice legislation did require...
If I interrupt, with
Yeah.
Medicare, they don't schedule the appointment, do they?
No,
Okay,
no,
that's...
No, and so I think what you're describing now, where we're seeing so many complaints is the veteran needs to go to the TPA to access choice. And so that has added a level of complexity. And this is where we've submitted legislation for your consideration to try to simplify and streamline these care in the community programs. Because we agree with you, it's too complex today.
Yeah, that's why I asked first in this is, do we need any legislative changes to allow the veteran to make their choice directly? And I don't think so. But I appreciate that. With that, Mr. Chairman, I yield back.
Thank you, Mr. Yulskamp. Mr. Takano, you are now recognized for 5 minutes.
Thank you, Mr. Chairman. Is it Dr. Shulkin? So there are some aspects to the legacy Vista system that you definitely want to see preserved and continued. Am I understanding that correctly?
I think there are many, many good things about the Vista system, and Vista Evolution, which is the newer sort of what we call eHemp, it's the web-based version, is also has many, many great features. I think at the same time, What Ms. Council's saying is that she wants to make sure, and we're going to do this together, that this is the appropriate technology for the future of VA.
And you're going through that evaluation process now?
Yes.
Okay. You know, I mean, I heard about the 130 separate systems. You're going to use the cloud and try to get all this to work together. And you're also looking at possible, a major replacement or not. You're sort of trying to figure all that out. Is that correct?
We actually have defined a new technical digital healthcare platform for VHA. It's currently being looked at by the users, and I am currently looking for an ability to build a prototype so that we can show it to you, but also so that the users can play with it. It leverages the EHR as a health record and does not have all that complexity that Vista has in it, and so we're agnostic as to which VHR, but it also is in the cloud, it's highly agile, and it's highly interoperable with care in the community, the DOD, and anyone else that we'd have to engage with on behalf of the veteran.
So that leads me to this next question. Dr. Shulkin, in your testimony, you mentioned much of what, is it Dr. Counsel or is it Ms. Counsel?
Sometimes, it depends on whoever you want.
That the VA plans to expand partnership with health information exchanges that are outside the VA, or HIEs, to improve access to health information between the VA and community providers. I want to mention that we have a very, very successful HIE in the Inland Empire, the region of California that I represent and Dr. Ruiz represents. And we actually, by the end of the year, expect that health information exchange to include all of our hospitals in our region, a 3 million population strong. And we even, in other parts of Southern California, other parts of California, rather than start their own HIEs, are actually leveraging off the work that our HIE has done. I understand it supports 9 million patient files, and by the end of the year, we'll include all the hospitals by the end of the year. How has the outreach to HIEs gone, and what challenges do you face as you look to form partnerships with HIEs, such as the one I just described?
Well, completely agree with you, Congressman. When I was running hospitals prior to taking this position, I was participating in functional HIEs. So VA wants to be part of these regional HIEs. We currently are partners with 71 today, 71 HIEs active throughout the country. That's where it does impact 475,000 veterans today, where we're exchanging records with 713 hospitals as part of these 71 community partnerships. So we want to expand that. It's the future, and it's the only way that you're going to make community care and VA care work as an integrated network.
And what is your timeline for that? What is your timeline to get that done?
It goes region by region because as you said, some regions are really pushing it and others are a little bit slower to get there. But part of what we're doing with the revised Care in the Community program that Representative Hulskamp asked about, we are using the $421 million to accelerate a VA portal into these HIEs.
And how of the 77 that you already are doing partnerships with, how meaningful is the interoperability?
It's an exchange of documentation, an exchange of lab information, medical record information. It's what HIEs do. I mean, you don't enter new data into it. It's really read-only capabilities.
Okay. Thank you, Mr. Chairman. I yield back.
Thank you, Mr. Takano. Dr. Shulkin, using VAR, can the veterans actually see a calendar for available appointment slots?
Yes, Mr. Chairman. In relatively limited today, primary care and mental health, but they can see what appointments are available to them, so they select what's best for them.
And what happens if the veteran requests, say, 3 dates that are not available? What would occur in the system?
I assume that if it's not working for them, because I would call that not working, I'd be frustrated. They have to pick up the phone and call. But Alan, do you have a better answer?
If the 3 dates they selected with the VAR system were not available, they'd have to either pick up the phone, as Dr. Shulkin said, or make a subsequent request.
So let me just say something. I think we're coming full circle on this, that we instituted the choice program because of problems in the VA scheduling system. Secretary McDonald was in Denver, Colorado last weekend, and his statement about the so-called quote-unquote scandal was that it was merely a lack of training of VA appointment personnel. I differ with that. I think it was fundamentally due to corruption, that they had manipulated the system in creating secret lists in order to get cash bonuses. And you know, there's not even an acknowledgement of that. I think only 6 people out of what was a systemic problem were held accountable, that were responsible. And so I'm very concerned about going full circle and giving it back to the people that created this problem. They caused us to enact the choice program, and where we have programs like Medicaid, Medicare, TRICARE that don't require that. And so I just want to state my reservation about this. I think there's some other things that are being worked on that are very important. Obviously, I had a discussion about cybersecurity yesterday and was very disappointed in the answer that I received on that. But I think there's a cultural problem here that's not been resolved. And let's see. Ms. Brownlee, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. I appreciate it. I just wanted to follow up on my line of questioning earlier with regards to, you know, the core VISTA system, and it's my understanding that the independent assessment recommended the VA conduct a cost versus cost-benefit analysis between a commercial off-the-shelf product or continuing the use of the VISTA health record currently in use. So is the VA undergoing that, or what are we doing?
We actually.
It sounds like you're thinking a lot about it, but
No, we actually have done the business case. The business case analysis was done last fall. Based upon that, we decided that the right thing to do is lay out the new digital health platform, because that's really what's needed for the future. If VHA is going to provide health care in the future and today, it needs to move into a digital platform, and that's what we've laid out. We're building the view for it so people can see what we're talking about, and Dr. Shulkin is looking at it from a functional point of view and the user.
So when you say you've done a business analysis, that's not really a cost-benefit analysis, is it, or?
The business case is a cost-benefit analysis, looking at the overall long-term ability to maintain it, what it would take if we wanted to change it, how could we get it onto an architecture that is more agreeable and agile so that it can move and change as healthcare is changing. Also, how will we work with the care in the community? But fundamentally, 4 core things need to be in a healthcare system. You need to have clinical management. You need to have hospital operations capability. You also need to have the veteran experience core to what we offer, and you have to have predictive analytics. We do not have that today with VISTA, and so we decided to pull and build the new digital health platform to address it after reviewing that business case last fall.
Okay, very good. And, you know, I would like to know more about the digital health platform and all of the different possibilities in terms of how it can support veterans and their needs. I know I mentioned this to you in my office yesterday, and one of my frustrations, and I think probably all of us who sit here on the dais, their frustration is that we never, in terms of accountability, we never seem to have an agreed upon matrix of what we're looking for, and let's just talk about scheduling and wait times is one of those metrics. And so I'm just hoping that as we proceed in this system, that we all can agree on what we're looking for and how we can hold you accountable and ourselves accountable for making sure that we are meeting the appropriate needs that we're looking for. Because I think sometimes we have, you may be looking at something, but we're looking for something else, and those two issues never seem to meet.
And that's a core backbone of the new development, because you need analytics. That's what you really want to understand. How well things are performing, how well are we responding, and frankly, how well the diagnoses and what we decide to do for the veteran is actually working for that veteran.
Right.
That is core to this system, and it doesn't require human interface to get that information.
Well, and I think we need to have that discussion about what those what are we going to get from those analytics, and so that we all have a sort of a common understanding of it. And just one last very quick question, I don't want to dwell on this, but we obviously have spent millions and billions of dollars on trying to make an IT system that works. And I guess my question is of those millions and billions of dollars that we have spent, was any of that money, in essence, sort of worthwhile in terms of what you're building on and trying to come to today?
Yeah, first of all, seeing patients in the system and using Vista, the country should be proud that we developed this system. Doesn't mean that it's going to be the system for the future, but it's working today. Millions of veterans' lives depend upon it, and it helps VA provide better quality than the private sector in many, many measures that's consistently published in the best journals in America. Secondly, VSE, which is Vista Evolution, which is where this $510 million went to over the last couple of years, is actually now being launched. April 5th, it went into 5 sites. So you're finally seeing, with all these years in development, all that money, it's actually now, just this April, being put into the system. It's going to be a major advance. So whether all of it was necessary, whether it could have been done more efficiently, I'm sure that it could have been done more efficiently, but absolutely not a waste, Congresswoman. It's here now.
Thank you very much, and thank you all for your testimony. I yield back.
Thank you, Ms. Brownlee, Ranking Member Brownlee. Dr. Benishek, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. I got just a few more questions about where I was when I was asking the questions last time, and this DOD, VA interoperability now. So there was 55,000 VA people who are able to access both DOD and VA records of veterans. We're not sure the amount of veterans that they're actually able to access. Are these health, and I wasn't sure because I think maybe you answered them in different ways. Are these health professionals that have access to this, or are these veteran benefit people that have access? Both. So, and then what percentage of this, I don't know, how many people are we talking about? 55,000, is that, what percentage of that? I mean, is that 10% of the system, or?
Well, of health professionals, it may be as low as 20-25% of the system.
All right, okay, that's kind of where I was going there.
Yeah.
So there's some definite work to be done there.
Absolutely. Training, yes.
So it's basically a training issue then, you think?
It's primarily a training issue. You have to, it's not easy, at least not easy for me. You have to leave,
So
you
then by
have
the
to go out of
deadline
a
in
system into
December,
a
you
new
think
system.
we'll have that better then? I mean,
Yeah.
full up to speed then, Ms. Counsel?
Yeah, it's an integration issue with Vista, and that's one of the reasons we need to get to a new digital health platform. Everything's separate, and that is the root of the issue.
I want to ask another question now. This is still about this self-scheduling thing. So we're not going to, in the consolidation, then we're not going to rely on the third-party people to do the scheduling, or we don't know that yet? Or, I mean, see, I have a problem with the veteran calls, I need an appointment. they get the appointment, and then the eligibility and everything's figured out later? I mean, how's that going to actually work, Dr. Shulkin?
Yeah. We know the current system isn't working the way it should for veterans. No disagreement there. So what we have proposed is a new streamlined system. We've actually released this week a draft RFP to the industry to seek industry partners who could help us do this better. We believe VA can't do this alone. I hear the skepticism. I don't think we're trying to say that we should be doing this alone. So we are seeking, and the RFP will be released, a full one, later on this spring with a selection in the fall, for partners to help us do this better, because frankly, this is what many managed care plans and other companies are doing much better than we are right now.
All right, okay. Let me ask another question. Now, there's this fee-based claim system that, is involved in paying providers in the community, and apparently the VA has this auto adjudication update possibility to speed this along. Do you intend to make that happen, or, I mean, this is a problem with the payment issue?
Yes, we
Story
do.
there.
Yes, we do. As part of the integration for community care, it includes eligibility, referral authorizations, provider payments, and customer service being tied into one service. So we can see that seamlessly, because it can't be done choppy like it is right now. Right now, it's very human labor intensive.
So is that something that's going to happen soon, or you have to wait till the whole integration's done, or, I mean, can it just be done now, or, and then?
No, I think what we needed were the requirements coming in from the business partners, which we now have. We can make the changes and then upload that system.
All right, well, I'm just got a few more minutes here, so I'm just going to comment. This has been an ongoing issue, and I appreciate you working on all these things, but it seems to me that in the private sector, many of this IT stuff is, the problems are solved, and then the system is improved on a constant basis, rather than trying to develop a huge, comprehensive fix, and then, by the time the fix is actually figured out, it's obsolete, so why isn't that more the way we're doing this than what seems to be happening here?
That is actually the way it should work. We have 365 data centers within the VA, 130 instances of Vista, and 834 custom systems. In addition, they're spread out across the 1,500 health systems, and it was built as it went. It looks nothing like what you would see in private industry, and fundamentally what we're laying out is a digital health platform that will get us there. I 100% agree with you. You don't have to get 100% of the solution in place to start. You can start with 20, 30, 40% and just get better over time. But that requires a standard platform. It requires one instance, one solution, and a process that everybody uses, and that was not how the VA was built.
All right. I'm out of time. Thank you, Mr. Chairman.
Thank you, Dr. Benishek, and thank you to our witnesses. You are now excused. I ask unanimous consent. What's that? Oh. I ask unanimous consent that all members have 5 legislative days to revise and extend the remarks and include extraneous materials. Without objection, so ordered. I would like to once again thank all of our witnesses and audience members for joining us in today's discussion. With that, this hearing is adjourned.